And then the last, picking up where we left off in the last video, the last one is the cardiovascular system. Generally includes the heart, the veins, the vessels, also the lungs, and any disruption. And if we back up, remember what arousal is. Arousal, remember the romantic arousal? It's just a bunch of blood pooling in the pelvis. And so that has to be able to happen in order for arousal to happen. And that particular part of sexual functioning is what requires an operational cardiovascular system. So when I'm listening to a client who's having some problems with sexual functioning, and they tell me they have heart problems or high blood pressure or low blood pressure, or they're on heart medication, these are all things that make me think, maybe this isn't just a psychological problem. Maybe they need to be referred. So that's definitely a system that needs to be working, and those are some examples of problems that can lead to sexual functioning problems. Okay. Another thing that's important to know is, in a similar vein, any medication that you use, that a client uses, can contribute to problems with functioning. Not any medication, but some medications are more generally likely to be culprits than others. For example, sorry about that. And when I'm talking about drugs and medications, I mean both prescription and illicit ones that are used for illicit reasons. Let me just generally say that the medication, in general, in terms of illicit drugs, uppers tend to speed things up. So amphetamine, cocaine, prescription medicine for ADHD that you're abusing, they tend to make things go a little faster. And downers, central nervous system depressants like alcohol, opiates, barbiturates, they tend to slow things down. So in general, people who use, like alcohol, for example, that tends to inhibit arousal, inhibit ejaculation, inhibit orgasm. Now, there's a caveat to that, and probably many of you are aware of this, that at low doses, it can disinhibit, it can psychologically disinhibit, it can make somebody feel more comfortable and relaxed. But once you get above that low dose, then it has a depressing function on sexuality. Some other common drugs that you'll hear about all the time include, let me just write this down here, the SSRIs is a common prescribed medication. Many of you know this, some of you are on it. This is called this stands for selective serotonin reuptake inhibitor. And long time ago in the 90s, I was actually practicing when Prozac came out. It was the first SSRI, and it acted in a different way than the antidepressants prior to it. And it has fewer side effects. In general, the SSRIs have way fewer side effects than the previous antidepressants. And by the way, the previous antidepressants were what were called let me see if I can write this here. Okay, so prior to the SSRIs, you had the tricyclics, which had a lot of pretty serious side effects. I mean, really a lot of discomfort and dry mouth, incredible somnolence, sleeping all the time. There's another medication that's sometimes used. That medication is called the MAO inhibitors, or the monoamine oxidase inhibitors. You don't need to know that whole thing. The interesting thing about this class of drugs is they're quite effective in the treatment of depression. I don't know if there may be more effective than SSRI, and sometimes have even been compared to something like electroconvulsive therapy. However, the MAO inhibitors, they have really severe side effects. Basically, if you eat wine or cheese, you die. If you drink wine or eat cheese, you die. There's something in it that the combination with the MAO inhibitor, so they don't prescribe that very much. So at any rate, in the 1990s, Prozac came out, and a whole series of drugs came out. Initially, the drug companies, as drug companies do, say, "Oh, these are perfect, no side effects." Of course, that's not true. That wasn't true, and it turned out one of the most common side effects was sexual side effects, like slowing down orgasm, inhibiting orgasm, or creating problems with arousal. both in males and females. So that's something fairly common. And by the way, most psychiatric medications, another one are the antipsychotic class of drugs, things developed to treat psychosis and schizophrenia. They also have sexual side effects, as do anticonvulsants and anything that operates on the nervous system. So you got to listen for that in your clients when they're complaining about these kinds of things. Some other psychological things that are related to the relationship that are necessary for good sexual functioning include, and this may seem to be a big fat duh, but there are some people where this does not hold true for. But knowing your own body is the requirement. It's important that you've practiced. And most sex therapists tell people to go masturbate and to try different things and find out what you like. You can't tell somebody what you like until you know what you like yourself. This is less and less common, but occasionally in my clinical practice, I still run into somebody who is from a conservative religion where they've never masturbated, they've never looked at their own genitalia. And there is something to be said, again, about this tends to be more common in women. I think it's hugely problematic for reasons I've already stated, that not young girl, but the teenager, the sexual debut, girls often know a lot less about their bodies than boys do, and it creates an imbalance right off the bat. Another thing that's necessary for sexual functioning, and I was involved in some research that studied this, was your ability to communicate with one's partner about what feels good. You have to be able to talk. And again, I know that sounds like a big fat duh in some ways. But I've mentioned to you before that sometimes people feel more comfortable having sex than having a frank discussion about it. I think that's unfortunate. But we did some research on this, again, in the 90s. This was my first research in graduate school. It was done by Mary Pat Kelly and Don Strasberg, and they repeated it. And they looked at women who had reports, and this was heterosexual relationships, women who had reports of anorgasmia or difficulty having an orgasm, and they compared them to women who didn't have that difficulty in the way they talked to their partners. So what they did is they showed them some erotic porn, okay, and they asked them to describe it to their partners. And they found the women who were orgasmic, they talked in much greater detail about the porn. They said things like, there he is with his penis, holding his penis, circling her clit with the tip of his penis. And they talked very specifically, whereas the women in the anorgasmia category were more like, yeah, he's kind of touching her down there. And they were much more vague in the way they described it. And so this, as well as some other evidence, you've got to be able to talk to your partner. So this is a non-medical thing that contributes to sexual functioning. So when we diagnose sexual dysfunctions, and as you'll be required to do a working diagnosis on the exam, assessment becomes very important. And assessment's always important. But really trying to understand the when, why, and how this problem happens for you, it's going to lead us to understanding how to help them with the problem. It's going to lead us to understand what percentage of this is physiological, what percentage is psychological. Like I said, most things are a combination of both. But I don't want to do 10 sessions of CBT with somebody focusing on their erectile dysfunction when they have something else going on, when there's a clear organic etiology. That will just make them feel bad about themselves that it's not working. It just sets up hopelessness. So I really the assessment is really to understand the etiology and thus the kind of treatment that's needed. So just a little bit of elaboration. I want to know, where does this happen? When does it happen? Is it all times of the day? Is it just at night? Is it just in the morning? Does it happen when you're alone? Does it happen when you're masturbating? Does it happen with every partner? And what's the mechanism by which it happens? When did it start happening? Did it start happening 6 months ago when you had a trauma? So I really want to put it together. I also want to ask, why are they coming in now for this? If they've had this problem for a year, Why are they coming in now? A lot of times there's been a change that's important to the clinical presentation, that maybe I just got a partner and my partner's finally frustrated with me. And that's important to know that their partner's frustrated with them, because that's going to, pressure is going to make it more difficult for them. So a brief sidebar about diagnosis. Here's this guy that tries it. Do not try it at home. It's tempting when you're a psychology student to want to try all of these things, or to want to use diagnoses on yourself or on friends. I think of diagnoses as being one of the biggest things we can weaponize in psychology. So there's a lot of things to diagnosis that we won't cover in this class. So just don't use this stuff on yourself, okay?